Hello, everyone, and welcome to Just Medicine. I'm Gina, and in today's episode, we're diving into an important topic with Dr. Astrid Williams. Today, we're talking about the unique mental health challenges faced by youth that are diagnosed with chronic illnesses. Specifically, in today's episode, we'll focus on adolescents that are dealing with inflammatory bowel disease, or in short form, IBD. IBD is a chronic autoimmune condition that encompasses Crohn's disease and ulcerative colitis. In this episode, we'll explore the prevalence of mental health challenges among these young patients, and we'll delve into the body image struggles that they may encounter while also discussing how they can navigate the transition from pediatric to adult care. Adolescence is a time of identity exploration, coupled with significant physical and emotional changes. Coping with a lifelong illness like IBD can intensify feelings of frustration, hopelessness, and isolation. Now, add to that the social stigma associated with IBD symptoms, and it's clear why managing these chronic diseases is especially challenging for younger individuals. The conversation that I have today with Dr. Astrid Williams sheds light on these important complexities. Enjoy the episode.
You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hi, everyone, and welcome back to Just Medicine. My name is Gina, and I'm a third year medical student studying at UBC. Today, I have a very special guest with me, Dr. Astrid Williams. Dr. Williams is a gastroenterologist with a clinical focus on pediatric to adult IBD transition and pregnancy in IBD. Dr. Williams completed her medical school training and GI fellowship in Sydney, Australia. She then completed a fellowship in IBD and a master's in health science at UBC. And after practicing a few years in Sydney, she's recently back to Vancouver, joining the IBD Center of BC. So, hi, Dr. Williams. Welcome. It's so great to have you here.
Thanks, Gina.
Absolutely. And before we get started, I know I introduced you a little bit, but I want to give you a chance also to introduce yourself and maybe tell us a bit about your background and how you became interested in the field of IBD.
Sure. So I graduated from medical school in 2007. I did that in Brisbane in Australia. And then the pathway in, at least my pathway had been to do a couple of years of more general training. And then I went into what we call basic physicians training, which is the equivalent of internal medicine training in Canada. And then after that, I specialized in gastroenterology, and that required at least 3 years in that specific training. And it was after those 3 years that I then came across to Vancouver and did a 2-year fellowship, and that was within inflammatory bowel disease. So having done a fellowship in inflammatory bowel disease, that then shaped my career subsequently with my development of expertise in the subspecialty of IBD. And then it's become even more specialised to some extent thereafter, as once I started working as a specialist in Australia after I returned from my fellowship in Vancouver, I was given the task of establishing a paediatric to adult transition service at the hospital that I was working at, and also developed, as you'd mentioned in my introduction, a pregnancy service for patients that are contemplating becoming pregnant or are pregnant in the setting of and having inflammatory bowel disease. I think the reason why I went into inflammatory bowel disease is a combination of factors. I'm attracted to the care of this condition, given it can affect a broad range of ages. And being a chronic illness, there's very much the establishment of a rapport with patient, and you get to see them in the highs and the lows and at various stages of their life. I've been inspired by mentors along the way that have similarly worked in inflammatory bowel disease and have provided motivation for me to pursue that direction as well. And then, as I mentioned, obviously coming to Canada after my initial gastroenterology training to then do 2 years specifically in IBD was further motivation to continue working within that field.
Amazing. Thank you so much for walking us through your journey in both Australia and Canada. It's always really nice to get to know our speakers both medically and also maybe a little bit outside of medicine.
The attraction to come back to Canada after, more recently, which actually was only earlier this year, is my husband and my attraction to the outdoor lifestyle that Canada has to offer. So, in particular, hiking or kayaking or other activities that are spent outside. Life is different though in the context of we now have 3 young children. So I have a 1.5-year-old, a 4-year-old, and a 6-year-old. So it's helping or working out how to navigate a balance between having the 3 young children. My husband's also a doctor, and then my own schedule. And I wouldn't say that we have it perfect, and we're forever trying to find that work-life balance. But we certainly still value the importance of having activities outside of work, and with having children, that demands that we do think outside of work on a daily basis.
That sounds very challenging, but Vancouver is the perfect place for outdoorsy things to do. So hopefully with
Yes,
the
exactly.
summer approaching, you get the perfect chance to experience some of that.
Yes, yes.
But just hearing your career trajectory, it seems very commendable, and it makes me really excited to have this conversation with you today and to get to learn a little bit about your experience both in IBD and also working specifically with the younger population.
Mhm.
So, with that being said, let's jump right in.
Yes.
So, in Canada, the incidence of inflammatory bowel disease has been steadily increasing. And like you mentioned, it affects a range of ages, but the peak age of onset is around 15 to 25, so quite young. And adolescents and the young adults that have to face this chronic lifelong condition often face a lot of challenges that are really important for us as healthcare professionals to pay attention to. This age group is specifically experiencing a lot of physical and psychosocial changes that can coincide with the onset and management of their disease symptoms. So, I was wondering if you could start us off by maybe giving us an overview of some of the unique challenges that young people have to face when they're diagnosed with IBD.
So I think the main challenge that I see, which would be applicable not just to IBD but to other chronic illnesses, is the need to be absent from all those activities that young adults would hopefully be able to take for granted. So that being either spending time with family or spending time with educational activities, be it at school or at university, or whether they have employment commitments to have. But I think the impact of the illness is such that time needs to be spent away from those more routine activities of becoming a young adult. And I think we may underestimate the impact that that absenteeism can have on the young adult. And it not just relates to whether they're unwell, such as if a patient is having symptoms which precludes them from, say, attending a school social function, but even whilst they are well and not symptomatic, there's still ongoing need for their attendance at appointments, or perhaps it may be to go for medication infusions, or if they have a routine assessment such as a colonoscopy. So even in the setting of having their disease under control, there's an ongoing impact of their condition with their ability to engage in all aspects of life that a young adult is already so busy doing so, but then to add in the extra complexity of having a chronic illness such as inflammatory bowel disease just has even more impact on their ability to live a normal life, so to speak.
Absolutely. And hearing you mention that actually reminds me of an article I came across by the Health and Quality of Life Outcomes Journal. And they were looking at the impact of IBD in pediatric populations. And they reported that 60% of children with Crohn's disease specifically have a significant number of absences from school. And
Mhm.
that 80% of them feel like they're doing poorly in school just because of their disease. And so this article was specifically just looking at school, but like you mentioned, being diagnosed with a chronic illness takes up a significant portion of a young adult's life, whether it's school, interaction with friends, family, or other things that they have to do, and that can have a lot of consequences even on their mental health as well. I also wanted to talk a little bit about the mental health aspects that come with a chronic illness. According to the Journal of Gastroenterology and Hepatology, the rates of anxiety and depression in patients with IBD in general can be up to 21 and 26% respectively. So they're up to 1.5 to 2 times as likely to have mood disorders. And one question I had was about the prevalence of these mental health conditions, specifically in younger patients that are diagnosed with IBD, and if you've noticed any trends or patterns from your experience so far.
So you're exactly right, Zina, in terms of the high prevalence of mental health conditions within young adults in general, but specifically in those with chronic illnesses such as inflammatory bowel disease. And there's been a recent survey of an Australian young adult population with IBD, and rates were as high as 50% for depression and anxiety. And that has been seen in other surveys globally. But I think we need to think beyond just depression and anxiety for the mental health impact. There's increasing interest and attention being drawn to post-traumatic stress disorder within the population of patients with inflammatory bowel disease. And as you could imagine, a paediatric patient with inflammatory bowel disease has no doubt been exposed to multiple instances of trauma, be it physical trauma or emotional trauma associated with their illness. And the impact of that, I think, needs increasing recognition and management to minimize an ongoing impact negatively from a condition such as PTSD. There is also an increased rate of other mental illnesses such as eating disorders, as well as the occurrence of self-harm. So the impact is profound of IBD and mental health. And then, as we were earlier discussing the potential impact of absenteeism on school performance, it has also been demonstrated that the coexistence of mental health conditions cannot surprisingly also impact educational performance in the setting of a chronic illness such as IBD.
Mhm. Hearing you walk us through that really reminds me of how important it is for us to consider mental health and emotional health, and not just anxiety and depression, especially when we're working with younger patients, because I think it's so easy to get wrapped up in a specific diagnosis of a chronic condition that we can forget how valuable it is to screen for the emotional well-being of a patient. Having these disorders, whether it's an eating disorder or PTSD or self-harm, can really significantly impact their quality of life, completely in addition to the physical burden of the disease. So I was wondering, have you seen a sort of change in the levels of integration of mental health counseling and mental health screening in the multidisciplinary care of patients with IBD over the years?
Yes, I think increasingly, as you've alluded to, there's been recognition of the importance of providing multidisciplinary care. And it's not just a matter of controlling inflammation per se or monitoring medications, but care needs to be provided in a holistic way, not just for mental health, but for other aspects, such as looking at potential complications associated with IBD or therapies. So monitoring for adverse effects, also looking at the nutritional aspect, both from a preventative as well as a therapeutic approach with regards to IBD. And increasingly, there are guidelines being produced or recommendations as to how IBD care can be best delivered. And that also relates to the delivery of transitional care for paediatric to adult care in the setting of IBD. And as the first part of that process is to formally recognise a problem, such as with the use of screening when first meeting an adolescent with IBD, and in particular if they're making the transition from paediatric to adult services. But in my experience, I think it's very easy perhaps to do screening, but there always needs to be a response to screening, in that it's one aspect is to recognize there is a problem, but then having an approach to how to manage that problem, including having review, obviously, of that screening, but then having a pathway depending on the severity of the outcome of the screenings to where the adolescent is then directed, and ideally having psychological services within the multidisciplinary team. And if that's not available, utilizing other online resources or psychological supports outside of that multidisciplinary setting.
Mm. Thank you for raising that point. I think having that sort of multidisciplinary care beyond just screening will impact the disease outcome as well. With emotional well being, it can also exacerbate IBD. And so, making sure that the patient's holistic care is being managed can really help ensure that they are receiving the management they need for their disease completely and comprehensively, and not just looking at it from an inflammatory aspect, as you mentioned. The next question I wanted to ask you has to do more with the social aspect of young patients' lives. And I was hoping if you could talk a bit about the emotional toll of feeling different from your peers when you have a chronic illness, and how this can impact social interactions and relationships as these young adults grow.
So, in my experience, from what I've observed, I think one of my main concerns of the impact of IBD and the emotional toll is the potential for the development of a sense of isolation. That they, I guess it's both a literal isolation in terms of they can't attend such events as we've already discussed, be it to go to school or to family events or other social events with peers. So they're physically isolated from that point of view. But then I think there's a greater depth to the isolation than that, in that they may feel that they are not relatable, that they can't convey or discuss or relate their symptoms or how they're feeling with their peers, as they're concerned about discussing it, or the stigma associated with having condition such as IBD, in particular, even the discussion with regards to what their toileting habits are like, or if there are other manifestations that are embarrassing to the adolescent, that then can be of a further isolation, create further isolation for them, which understandably has significant emotional consequences. I think another significant component of the emotional consequence can relate to self-esteem. So we can all recall being an adolescent, and I wouldn't say my self-esteem is perfect now, but certainly was much more difficult as an adolescent. And it's a change both emotionally and physically and mentally in somebody without a chronic illness, but then to have inflammatory bowel disease on top of that, and perhaps being more self-conscious, as for often growth is impacted. So growth or pubertal development may have been hindered as a result of IBD, or there may be disfigurement associated with IBD, such as in the setting of perianal Crohn's disease, or if there are other manifestations that have resulted from either IBD itself or as a result of the therapy used for IBD, such as psoriasis, that's providing an even greater impact on self-esteem, and then consequentially the feeling of isolation. So I think that those couple of points to me would be some of the more profound illness effect of the illness. And then as a consequence of that is the impact on the ability to form relationships, be it within the family or more broadly, and including sexual relationships, as well as the ability to participate in activities as a consequence of that feeling of isolation.
You brought up the point regarding how adolescents often feel like they're different from their peers. I can see as a young patient who has been diagnosed with a chronic illness, when you compare yourself to your classmates or your friends, or other people your age who appear happy and healthy from the outside, it can lead you to view yourself as undesirable or maybe even defective. And having these thoughts, along with the fear that you're being judged or criticized by other kids your age because they can't fully grasp your symptoms or your condition. And I think with IBD specifically, as you mentioned, a lot of the symptoms are very personal in nature. And I think anyone of any age doesn't really feel comfortable talking about how many times they go to the bathroom or what
Exactly.
their stool looks like, now let alone a young patient who's already very conscious about all of this. And so not only does that have a significant emotional burden, but it also, I think, makes it difficult for young patients to seek support when they need to, just because it's harder for them to open up. And it's also, I think, one of those conditions where maybe the symptoms don't always receive the same level of sympathy that other symptoms might. And so I think that also contributes to why it's harder for younger patients to open up and why they have poor self-esteem. Now, you did talk a little bit about body image. You kind of alluded to it a little bit, and I was wondering if you could delve a little bit deeper into that and how IBD commonly presents with body image issues, because we know that this is a very sensitive topic for most adolescents.
Mhm.
And so, how is it different in a patient with IBD?
Well, I think it's exaggerated in a person with IBD. And I guess, say, for example, particularly for a young male patient with IBD, in my experience, often there is self consciousness about what growth they have achieved, either that they're short or that they don't have the muscle bulk that they would desire to have, and that is an impact of their IBD, particularly if it is poorly controlled. But I think, as we just had already discussed, there's manifestations beyond growth, and that can relate to the physical manifestations of IBD with regards to there are some skin conditions that can accompany IBD, such as hidradenitis suppurativa, that really can have a devastating impact on a physical appearance for an individual. And then the other big one for inflammatory bowel disease is that of perianal Crohn's disease, which is not only painful but disfiguring. And both of those can have a significant impact on how the individual feels about their body, and certainly how the individual perceives others would view their body. So I think a combination of those factors would really have an impact on an individual's self-esteem at an already vulnerable time.
Thank you so much for touching on those points. As you mentioned, a lot of these symptoms have a lot of stigma associated with them, and so this can really have a negative impact on an individual's body image, especially in younger populations. Another challenge for youth with chronic illness, and this is something that falls really well in your line of expertise, but it's the transition from pediatric to adult healthcare. And in BC, this happens at around 18 years of age. I was wondering if you could discuss some of the challenges that young patients often encounter while they're transitioning to adult healthcare.
So I think the transition from pediatric to adult healthcare is also occurring at major transitions in life. So usually that young adult is transitioning from school to university or to post-secondary employment. They're transitioning within their own friendships, transitioning in terms of their role within a household. So I think it needs to be recognised that their transition with regards to how they're receiving healthcare is only one of many transitions that are already happening. And I think the challenge is also relates to the change in which healthcare is delivered. As an adult gastroenterologist, I'm happy to be the first one to admit that adult gastroenterology can be a different way of delivering care, in terms of adolescents will be surprised to come and find a much busier clinic. The clinicians usually allocate less time to spend with the transitioning adolescent than what, say, the pediatric gastroenterologist may have spent. There perhaps may be less allied health input, at least in the first instance, available. So there's a change in terms of how healthcare is delivered, and that relates both to outpatient care, but can also be relevant to inpatient care, or say the performance of procedures in relation to the degree of sedation that's provided. So I think that certainly would be perceived as a challenge for the patient. And then there are the increasing expectations for that young patient, as part of a transition, is attempting to empower the young adolescent or the young adult rather, to be taking on increasing responsibility, and for the parent to be taking on less responsibility. But in many situations, this is confronting for both the adolescent as well as their parent, as there's likely been a long period of time in which the parent has been overseeing the care beyond what is provided directly by the healthcare professional. And for that to be handed over to the adolescent themselves can be confronting for both parties involved. I think there's also the need for adolescents to be having more self-advocacy. So they're talking in the appointment, or the adolescent is the one calling up to make another appointment or to arrange medications. And again, this can be quite a daunting aspect for the adolescent, and no doubt would be perceived as a significant challenge. And I think that needs to be considered in the model in which an adolescent does transition from pediatric to adult care.
Mm. Overall, it seems like a period of lots of changes that seem like
Exactly.
it could be too much to take on all of a sudden. You mentioned that transitioning to adult healthcare, it's a significant milestone for young patients. And not only is this an emotional adjustment that they're going through, but it's also, like you said, an increased sense of responsibility, where in maybe pediatric care, it's more family centered. In adult
Mm-hmm.
care, the patient could be seen as kind of the one who's sitting in the driver's seat and they're responsible to, like you said,
Yes.
advocate for themselves, whether it's in terms of managing their medications or booking appointments or following up with their condition. It can be a lot of pressure and it can be very overwhelming if it's done suddenly or
Yes.
not in a way that
Yes.
feels supportive for the patient and their family. And so I'm curious what strategies you recommend or you use yourself to ensure that this process is done as smoothly as possible.
So I think I've actually the strategies that I have is from my own personal experience in terms of establishing a transition clinic and learning from mistakes. So, for example, when I first started a transition clinic, I had this vision that the last time the parent would be in attendance at the appointment was at the pediatric hospital, and then the next time they came for their first adult appointment, that the parent wouldn't be in the waiting room. Sorry, wouldn't be in the consultation room and instead be in the waiting room, at least initially. But I quickly learned that it needs to be a gradual process, as you've already alluded to, and it can't be a sudden change. And so gradually there needs to be more, that the young adult needs to have more of a role and the parent have less of a role, but that can't be expected at that first appointment. And I think that applies not only for the attendance at a clinic, but in terms of the responsibilities that a young adult is given in terms of whether it's to arrange filling another prescription or to report symptoms if they're unwell, to rearrange an infusion, that it's a gradual process with the adolescent taking on more and more responsibility. But I think that development of self-efficacy can occur even before there is the transition or the transfer of care, and even say from the age of 12 that there be a gradual increase of the adolescent's participation in the consultation away from the reporting of the parents to the adolescent actually providing information and gradually gaining more knowledge of their condition from as early as the age 12 to help then empower them and have them more ready for transition when it actually comes to the ready for transfer of care, rather, for when it actually comes from a logistical point of view that their care needs to then be changed over to the adult facility.
Mm. Thank you for sharing those tips. It seems like instead of it being something that suddenly happens at the age of 18, it's something that needs to be well thought through many years before the patient reaches 18. And then, as you said, even gradually after that. And I can see how, depending on the patient and family dynamic, this can also be different for different families and different patients, the way
Exactly,
you
to be
approach it.
individualized.
And I was wondering if you could speak a little bit about how you can ensure that sense of continuity of care and ongoing support for patients once they have transitioned to adult care. I know you mentioned how a little bit of it is different in comparison to pediatric clinics. So I was wondering if you could speak a little bit about how you maintain the continuity.
So I think an important aspect of a transition model, if it is possible, is to have a joint clinic or at least overlapping clinic. So by that I mean that ideally there would be a clinical appointment where both the pediatric and the adult specialist would be present with the young adolescent and likely their parent or caregiver, as well as other allied health providers involved. And so at that joint clinic, there can be discussion about the pivotal aspects of care that need to be handed over, but also providing the opportunity for an introduction to the adult service before the young adult has actually left their pediatric service. That's not always logistically possible depending on the clinic model or the funding of the service. So at least if that's not possible, that there has been some direct communication between the referring pediatric gastroenterologist to the adult gastroenterologist, and ideally that there may be some overlap in terms of the adolescent has a pediatric appointment, they then meet their adult gastroenterologist and then perhaps have one final appointment with their pediatric gastroenterologist. So to help provide continuity in terms of having some overlap of care. Ideally, and there's evidence to demonstrate the role of this, is that there's an overseeing transition coordinator, and this usually would be filled by the role of an IBD nurse. So an individual that has the allocated task of overseeing transition, and as you've already alluded to, individualizing it according to what the needs of that young adult and their family is, as there obviously can be difference from individual to individual. I think another way to help with the process is to be clear as to who the first point of contact is in the event that there are concerns or questions in between appointments. So the way that we managed it when I was working in Australia was that we would have a joint clinic, and then up until the time that the young adult came for their first appointment at the adult service, their point of contact continued to be the paediatric GI service up until when they actually had that first adult clinic appointment. And then thereafter, there were contact details provided for the adult clinic or the care providers outside of that clinic. So the individual was clear with whom they contact in the event of a problem in between appointments. And as with many IBD services or other chronic illness services, it's important that there is a point of contact, either an email or a phone number, so the patient does feel that they have ongoing support in between their clinical appointments. I think another way to help facilitate transition is obviously not just the transition in care in terms of the medical specialists, such as the gastroenterologist, but often there's many other members of the team involved. So if they've, say, been attendance with a dietitian or with a psychologist, so if there are other medical conditions that have other specialists involved, that there is a deliberate transfer of care and a transition process for the holistic aspect of care, and not just the one condition, such as the management of their IBD. I think there are also useful resources that can be provided, whether it's information about the centre to which they're going, or generally information that are age appropriate with regards to their condition, to help reinforce knowledge and encourage the skills that are required for that young adult to continue developing their self-efficacy and knowledge.
I really appreciate you touching on all of these from your experience, because I think working with youth who are transitioning to adulthood is something that we all will encounter as students, regardless of the field that we end up going into. And in our educational curriculum, unfortunately, the time that we spend on this is limited. And so
Mm-hmm.
it means a lot to me, and I'm sure our listeners, to have you give your guidance on how we can navigate this important aspect of working with younger individuals.
Great. I hope it will be of use for others as well.
Absolutely, I'm sure it will be. And this leads me to my next question, which is how can we as healthcare providers support youth in developing healthy coping skills to manage their mental health alongside their physical well-being?
I think in the first instance is drawing attention to the importance of it, so that there not be any taboo about talking about mental health, asking the questions or doing the screening surveys to show that it is a recognizable aspect of their care, and it's not just, say, their bowel symptoms that are of concern. And then as a result, encouraging discussion regarding their concerns, so that there's an openness to facilitate potential attention to mental health concerns. And I think encouraging the individual to take on the responsibility, as I've already mentioned, to be the one that is voicing the concerns, as opposed to leaving it to the parents or the caregivers, is important. And then I think providing supports at least in the way that I try to do it, is to provide supports or a list of resources, even if they're not required then and there, as there may not be a problem at that point in time, that they still can have access to a list of resources in the event that problems do develop later in the future, later down the track.
It seems like destigmatizing and normalizing mental health concerns is one of the critical aspects in order to help youth.
Exactly.
You
Yes.
mentioned resources, and this is extremely important because patients often get a limited time period with their physicians or other health disciplines that they're working with, and having access to these resources can come in very handy when patients are having concerns outside of that appointment with the physician that they can reach out
Mhm.
to or use. Are there any specific resources that you personally recommend to patients or that you really think are useful and evidence-based?
So, both within Australia and within Canada, there is access to the online resource of Headspace. So that would be one of the main ones that I would recommend. And I'm also familiar, both within Australia but also within Canada, the role of patient support organisations. So Crohn's Colitis Australia, for example, but obviously Crohn's Colitis Canada. And the Crohn's Colitis Canada webpage specifically has a part of the website dedicated to young adults with IBD. And within that, there is attention to mental health and discussion with regards to the problems associated or potential problems associated with mental health and IBD, and also potential solutions as to how to manage those problems. So I think specifically for IBD, obviously it's Crohn's Colitis Canada, but I would say for many of the chronic illnesses that your fellow students may encounter is seeing what individual patient support programs there are available for those illnesses, as often that will be a resource that will be specific to that chronic illness to help with providing the resources for mental health.
Just as a note, any of the resources that you mentioned and that we discuss in this video will be linked in the description box for this
Mm-hmm.
episode in case anyone or any of our listeners want to check it out later. But building on our discussion, I was wondering if you had any examples of strength and resilience that you've seen in youth patients personally.
Yeah, there is actually one particular patient that I will refer to as JT. He was diagnosed with IBD as a baby. So there's a subgroup of IBD which is called very early onset IBD, and as a baby he was diagnosed with Crohn's disease. And early on in his infancy, he required surgery, and so he had a much of his colon removed and has had a stoma for much of his life. And I met him soon after starting as a consultant, a gastroenterologist at the centre I was working at in Sydney, because he was transitioning. I can still vividly remember the joint transition clinic that we had at the Children's Hospital, where his gastroenterologist, who had known him for 16 odd years because he'd known him since the baby, was handing him over to my centre's care. And that was quite daunting. It came with a lot of responsibility to be continuing to care for such a patient. And he was just finishing school at that stage. And I have been so impressed as to the milestones that he's made since then. So I've seen him finish school, he's done a trade, he's now working in that trade. He has a girlfriend and has maintained a relationship. And another major aspect of what he's had to face and what he's successfully done is to face having another surgery, which was to remove the remaining rectum, as he had a small amount of rectum remaining, which was not of any purpose because he was not ever going to have his bowel joint back up because of the nature of his Crohn's disease. So will have a permanent stoma, but he needed to have the remaining part of his bowel, the rectum, removed, as it was sitting there and wasn't functional, as potentially could develop cancer. And over a couple of years, there were discussions between myself and a colorectal surgeon and JT about this surgery. But the impact of the surgery is fairly significant, as any pelvic surgery does carry with a risk of infertility. And so to be talking to a young male in his 20s about needing to have a surgery that could potentially affect his fertility was obviously of significance, both for the clinician and the patient. So JT had to navigate having sperm banking prior to the surgery, navigate going through the surgery, and do all of this while maintaining the role of a boyfriend for his girlfriend, but also working in a trade. And just before I left Australia, I had an appointment with him, and he came in and he was flourishing. He had got through that surgery, continued to work, maintaining his relationship, and just to see him come through all of that and yet do so well was really an inspiring moment in my career, in particular for looking after young adults with inflammatory bowel disease.
Wow, that's truly empowering to hear. It seems like the disease really matures you really quickly, and
Yes, yeah, that's a very good point. Yes.
yeah, and you have to navigate all these complex medical diagnoses and all these challenges that the disease and the appointments and the treatments and the side effects all throw at you. And it seems like so much, but hearing these narratives and the story that you mentioned is important because they're reminders of how resilient and courageous and strong these individuals are, where they have to fight and battle with this disease on a daily basis. And IBD doesn't have a cure and it's a lifelong disease. And the fact that they have to wake up every day and battle against this it's truly empowering to hear. So it means a great deal for you to share that story with us.
Thank you.
Unfortunately, we are approaching the end of our discussion. And before we end this off, I just wanted to ask you if you had any key takeaways for our listeners, where if they take one thing away from this conversation, this would be it. What would you say that takeaway is?
I think it's that the patient is not the disease. So, particularly for young adults, I think there has to be more discussion about what medication they're on or how many poos they're doing a day. There's obviously so much more to that individual. They have interests, they have relationships, they have aspirations. And I think no matter what their low point is, we need to remember that we're treating a person and not a condition, and that they're not labeled as the IBD patient, but they're referred to as their name and what they're hoping to do once they finish school or once they finish their university, and that we see that individual holistically and not just in a medicalized way. And start your encounter with the patients that you meet as, you know, what's your name, what do, what do you want to do, and not, oh, what are you doing here, or again going straight to medical questioning. They need to be recognized as the individuals they are and not for the condition that they have.
What a good takeaway to end us off on. And I think this applies to almost every medical condition and every patient we see. It's to really humanize the patient. And like you said,
Exactly.
see beyond the diagnosis because they are someone's son or daughter, someone's
Yes.
friend. So it's important to see them beyond that. But I wanted to thank you so much, Dr. Williams, for taking the time to come and have this conversation with us about mental health challenges of youth with IBD specifically and chronic illnesses. It's been a pleasure chatting with you and learning from your experience on this very important topic. So I really appreciate that. So thank you again for joining us.
Thank you. And you need to be congratulated on all that you're doing for the medical community. I'm sure it's having a significant impact.
Thank you so much, Dr. Williams. And to our listeners, thank you for tuning in and stay tuned for more engaging episodes in the coming weeks.
Thanks for tuning in to Just Medicine.